Hello everyone, this is Dr. Said again, and in this lecture I will be talking about the abdominal viscera and the vasculature. And again, for your convenience, I have divided this lecture into three short segment videos. I hope that will help you keep focus actually on the content. So, when we talk about the abdominal viscera, we mean the lower part of the esophagus, which we also call the abdominal part of the esophagus. That continues in the stomach, the duodenum, and the last part of the small intestine, large intestine. In addition to the luminal GI tract, the abdominal viscera also includes the liver, the gallbladder, pancreas, and you will have spleen around here, which is not shown in this picture, and also the kidneys. In the first lecture, I will be talking about only the luminal GI tract and their blood supply. So, which means we'll start our discussion with the abdominal part of the esophagus. Okay. So now, before we get into the detail of individual segment of GI tract, let's talk about a few things that will apply to all abdominal viscera. Okay, so that is how do we describe the position of the abdominal viscera? Okay, and it's important when you see a patient and you want to clinically examine the patient. It is very important for us to know the position of the viscera. We should be able to explain the position of the viscera, and also we need to know their surrounding structures, their relation with the surrounding structures. Okay, so in order to do that, two different schemes are used. In one, the abdomen is divided into four quadrants by a median plane, which is also called the mid-sagittal plane, and also a horizontal line which passes through the umbilicus, and it is called the transumbilical plane. So these two planes divide the abdomen into four quadrants, like the upper right quadrant, which contain the liver and the gallbladder, and the left upper quadrant, excuse me, which has the stomach and the spleen there mainly, and the lower left quadrant, which will contain the distal part of the descending colon, the sigmoid colon, and the right lower quadrant, which, as you can see, will contain the cecum, appendix, and these are the structures mainly. That's how we describe the position of the abdominal viscera in four quadrant pattern. Okay, now in another pattern, the abdomen is divided into 9 regions. So how is abdomen is divided into 9 regions? So two vertical planes are drawn through the midline of the clavicle, called the mid-clavicular plane. So these are the two mid-clavicular planes. And then there are two horizontal planes. One is drawn below the costal margin that goes underneath the 10 costal cartilage, called the subcostal plane. And posteriorly, it passes through the body of the L3 vertebral body. And the lower horizontal plane is drawn joining the iliac tubercle or the tubercle of the iliac crest. Okay, so there is a landmark called the tubercle of the iliac crest, and a line drawn to join the tubercle of the iliac crest on both sides is called the intertubercular plane. So now by these four lines, the abdomen is divided into 9 regions. And like this one is called right hypochondrium, this is the epigastric region, this left hypochondrium, and then in the center you have umbilical region, then on the right you have right flank, on the left you have left flank, and again in the center is the pubic region, on the right it's the right groin or right inguinal region, and the left groin and left inguinal region. So that's how the abdomen is topographically divided to describe the position of individual viscera. Now, in some text, you will see in place of subcostal plane, they use a different plane called transpyloric plane. Transpyloric plane is drawn a line between a horizontal line that is drawn between the jugular notch here and the pubic tubercle here. So that will go somewhere around here, okay, and that will go through the L1, lower border of the L1 vertebra. That is called the transpyloric plane. Okay, in some texts they describe, instead of subcostal plane, they use transpyloric plane to divide the abdomen into 9 regions. Okay, so now let's start talk about the individual segment of the abdominal viscera. So now we start with the esophagus. Only a small portion of the esophagus is in the abdomen. Okay, most of the esophagus is either in the neck or in the thorax. You have seen esophagus in the thorax, but as we are talking about the esophagus, let's go over the whole esophagus quickly. The esophagus is a flexible muscular tube that begins in the lower border of the pharynx and continues through the neck, through the thorax, and it enters the abdomen through an opening in the diaphragm, which is called the opening in the diaphragm called the esophageal hiatus, that lies at the level of T10 vertebral level. Okay, so that's how esophagus entered the abdomen, and it quickly ends at the junction between the esophagus and stomach. We call gastroesophageal junction. Okay, so as I said, the esophagus is a flexible muscular tube. So esophagus is composed of upper part of if we divide the esophagus into 3 parts. So upper 1/3, then this is the middle 1/3, and this is the lower 1/3. Upper 1/3 of the esophagus is composed mainly of skeletal muscle, which is skeletal muscle component. Lower 1/3 of the esophagus is smooth muscle. Now, middle 1/3 of the esophagus is more like a transition zone where, the skeletal muscle is gradually replaced by the smooth muscle. Okay. Now, because it is a flexible tube, it can be easily compressed by the surrounding structure. So 3 constrictions are important for you to know. One is at the beginning of the esophagus, where it's a junction of pharynx and esophagus. That is called the cervical constriction. And then there is one called thoracic or aortobronchial constriction. That is in fact, there are 2 constrictions here. One constriction is caused by the arch of the esophagus on the arch of the aorta on the esophagus, and the second one is by the left principal bronchus on the esophagus. Okay, so one by the arch of the aorta, the other one caused by the left principal bronchus, and then the last constriction is at the entrance of the esophagus in the abdomen from the thorax, as the esophagus travels through the diaphragm. Okay, we call it diaphragmatic constriction, that is located at the entrance of esophagus through the diaphragm. Okay, so why it is important for us to know about this site of constriction? Because if you want to send a instrument, medical instrument, for an example, one common example is if you want to do a endoscopy of a patient, you need to send the endoscope through the esophagus into the stomach, right? So to do that, you need to know those areas of constriction, because they will give you more resistance as you go through those constricted areas with those instruments. Okay, so that is important for you. So you will expect those additional resistance as you travel through those constricted areas. In addition, because those areas are constricted, any ingested object will be lodged in one of those constricted areas. More likely they will be lodged over there. And also, if someone ingests something which is irritating or corrosive, they will travel through those constricted areas relatively slowly, causing more damage to those constricted areas. Okay, now 2 transition is important for you to remember here. One is the transition from the skeletal muscle that form the upper part of the esophagus to the smooth muscle that form the lower part of the esophagus. One is the transition from the skeletal muscle to the smooth muscle. Another important transition, which is histological, microscopic, you will not see it in gross anatomy, that is at the junction of the esophagus with the stomach. We call gastroesophageal junction. If you look at this H&E stained slide, you can see this area of the lining epithelium is stratified squamous epithelium, and at the junction with the stomach, it quickly changed to simple columnar epithelium. Okay, so for the GI tract lining from the oral cavity all the way to the end of the esophagus, its lining epithelium is stratified squamous, beginning at the gastroesophageal junction all the way to the upper part of the anal canal. This is all simple columnar epithelium. So this is an important information that you need to know. Now let's go to stomach. Now the stomach is divided into, stomach begins at the gastroesophageal junction where the esophagus ends and the stomach begins. The junctional part right at the junction with the esophagus, that part of the stomach is called the cardia of the stomach. And then you see an angle that is formed by the entrance of esophagus in the stomach is called the cardiac notch. If you draw a line from the cardiac notch all the way to the greater curvature of the stomach, then upper part is called the fundus of the stomach. Okay, and then the main part of the stomach is the body of the stomach. Okay, and then there is on the lesser curvature two curvatures of the stomach. This is the lesser curvature and this is the greater curvature of the stomach, right? Now there is a bend in the lesser curvature called angular incisure. Okay, so if you draw a line from angular incisor to the greater curvature of the stomach, then the remaining part of the stomach is called the pyloric part. Now, initial portion of the pyloric part is little dilated. We call it the pyloric antrum, and the relatively narrower part is called the pyloric canal. Okay, so the last part of the pyloric canal, you can see there is a constriction. Okay, that is called the pylorus, where the stomach ends and the duodenum begins. That constriction is formed by the thickening of circular muscle of the stomach that I will show you in the next slide. Now, about the surrounding of the stomach, a few things that you need to know. Anteriorly, stomach is related to, as you see, the liver is lifted up. That's why you don't see that relation. Normally, liver fall on the anterior surface of the stomach, part of the anterior surface. So if you want to know about the anterior relation of the stomach, that will include the liver, and most of the part is related to the anterior abdominal wall. So these are the main relation of the anterior aspect of the stomach, and the posterior part of the stomach is related to the part of the transverse colon, the spleen, the left kidney, and also another structure lies right behind the posterior aspect of the stomach. We say those forms the stomach bed, that is the pancreas. So stomach bed is on the posterior aspect of the stomach where the stomach rests, is composed of the pancreas, the part of the spleen, part of the left kidney, part of the transverse colon, and peritoneum related to transverse colon is called transverse mesocolon. Okay, now look at the peritoneal reflection. One is coming from the inferior surface of the liver to the lesser curvature of the stomach. This is called the lesser omentum. Okay, and the lesser omentum has two parts. One, the part that is between the liver and the lesser curvature of the stomach, that is called the hepatogastric ligament. Excuse me. And the part that runs from the inferior surface of the liver to the first part of the duodenum is called the hepatoduodenal ligament. Now, one thing that I want to remind you here is that when you hear about the terms like the mesentery, ligament, omentum, okay, these are all peritoneal folds, okay, double layer of peritoneum. This is a double layer of peritoneum. Here we call it omentum, running between the liver and the lesser curvature of the stomach. Now, when we talk in between the two organs, between the liver and the stomach, we call it a ligament. It's the same thing. Now we call it hepatogastric ligament and hepatoduodenal ligament. So normally they are all, so this mesentery, these ligaments, and this omentum, these are all two layers of peritoneum. Normally when they connect one organ to the other organ, generally we call it ligament. When it runs between the posterior wall of the abdomen, mostly, to the organs, we call them mesentery, right? So when we say the mesentery, that is the peritoneal double layer of peritoneum coming from the posterior abdominal wall to the small intestine. We call it the mesentery. Also, part of the mesentery is the part of the peritoneum that runs between the posterior abdominal wall and the transverse colon of the large intestine. We call transverse mesocolon. And the part that connects the posterior abdominal wall to the sigmoid colon, we call sigmoid mesocolon. So anyway, the point that I am trying to make is that this omentum, this ligament, this mesentery, these are all double layer of peritoneum. Okay, so don't be confused by different name as we use in a different place. One more common example is here. Initially, the whole thing we call lesser omentum, but when we talk about its two parts, we say this is composed of hepatogastric and hepatoduodenal ligament. See, once we are saying ligament, the next time we are calling it an omentum, which means they are all double layer of peritoneum. Another important thing that I want to remind you here is that the hepatoduodenal ligament is very important because contained within this hepatoduodenal ligament are three very important structures. They are bile duct, a hepatic artery proper, and the portal vein. These three very important structures are contained in the hepatoduodenal ligament that you need to know for sure. And also, you see there is a free edge of the lesser omentum or the free edge of the hepatoduodenal ligament. If you insert your finger underneath it, that will take you to the lesser sac. The peritoneum is composed of two sacs. One is the biggest, the greatest sac of the peritoneum. The other one is lesser peritoneal sac that lies behind the stomach. And this is the entry actually. This is the communication between the greater sac and lesser sac. This opening is called the epiploic foramen or foramen of Winslow. Okay, so if you insert your finger through this, that will lead you to the lesser sac of the peritoneum. Now, it is important for us to know that anterior to the lesser, if we look at the boundary of the epiploic foramen or foramen of Winslow, anteriorly it has a relation of three very important organs again: the bile duct, hepatic artery proper, and the portal vein. Posteriorly, you have the inferior vena cava. So this opening is very important. Posterior to it is vena cava. Anterior to it are three very important structures. So if you have to approach the lesser sac through this foramen, you have to be very careful because you have very important structure anteriorly, you have very important structure posteriorly. Again, posteriorly will be inferior vena cava, anteriorly will be bile duct, hepatic artery proper, and the portal vein. Okay, so inferiorly it will be the first part of the duodenum, and superiorly it will be the caudate lobe of the liver. So that is how the boundary of the epiploic foramen is described. Okay, now let's so here this shows the position. If you see in the 9-quadrant pattern, if we have to describe the position of the stomach, say, then we'll say stomach will be located in the left hypochondrium, it will be in the epigastric region, and it will extend into the umbilical region as well, right? So that's how the position of the stomach here. Now, a few things about the interior of the stomach. We will not talk much about it. If you see an open stomach in the lab, you will see the interior of the stomach is marked by these longitudinal folds. These are called the rugae of the stomach. They are important because excuse me excuse me. So these, when stomach had to accommodate large volume, so these rugae they flattened out to accommodate more volume inside the stomach. Okay, and again you can see the greater curvature of the stomach. This is the lesser curvature of the stomach, and look at here. The stomach is composed of, the whole GI tract actually is composed of two layers of muscle. Normally it is outer longitudinal and inner circular. So outer layer of muscle coat is longitudinally arranged and inner coat is circularly arranged. So, and you can see the thickening of the circular muscle at the pylorus form a pyloric sphincter. This is important. That allows the sphincter action of the pylorus that allow gradual movement of stomach content into the duodenum. So it doesn't allow the whole thing of the stomach content to quickly move to the duodenum. This gate allow only gradual movement of the stomach content into the duodenum. Okay. So, and one more thing about this segment of the lecture is, see, the part of the stomach and the abdominal esophagus may herniate into the thorax through the opening in the diaphragm, which is called the esophageal hiatus. Two types of this hernia. One is called the sliding hiatal hernia, where the abdominal part of the esophagus and part of the fundus of the stomach herniate into the stomach through the esophageal hiatus in the esophagus in the diaphragm, which is more common of the two hernias. And this one is called the paraesophageal hiatal hernia, where the abdominal esophagus remain in its place, but a peritoneal pouch along with the part of stomach, mainly the fundus of the stomach, herniate into the thorax. Okay, so these two type of hiatal hernia, they are called hiatal hernia because the part of the stomach or esophagus herniate into the thorax through the esophageal hiatus. That's how the name came, hiatal hernia. Now, two type again. One is sliding hiatal hernia, and the other one is paraesophageal hiatal hernia. Okay, I think that is all I have for this one, and I will start the next segment soon. Thank you for your attention.